Guidelines for the management of postpartum hemorrhage for Pakistan, July 2023 is the topic of our discussion today. Neglect and poor management in health facilities have contributed to deaths. Misadventures contributed to 36% of maternal deaths and to 75% of the deaths due to primary PPH. Most deaths occurs within 2 hours of the delivery. Rapid action is critical for survival. Majority of the women who experience PPH have no risk factors. Early recognition of this condition may result in saving many lives. Recent scientific evidence and new technological developments have necessitated changes to the management of PPH in Pakistan in line with the guidelines from WHO, FIGO, ACOG, RCOG, FOGSI, and other major international obstetric and gynecology professional bodies. PPH guidelines using bundle approach of management with early detection have helped improve the care of women all over the world and in Pakistan as well. Care bundle approach of management have been associated with improved patient outcomes. The goal of PPH bundle is to reduce the frequency of severe hemorrhage and improve maternal outcomes. Shock index. It is defined as the ratio of the heart rate to systolic blood pressure, and it is very simple to use and has better predictive ability than other vital signs because it detects acute changes in maternal cardiovascular system. Evidence-based prevention and management of PPH can be achieved with early accurate measurement of the blood loss and timely treatment. Early detection of the PPH treatment triggers include the use of calibrated drapes for collection of the blood, with the trigger lines at 300 ml and 500 ml for the first hours after birth. Postpartum monitoring of the blood loss, blood flow, uterine tone every 15 minutes, documented on blood loss monitoring chart along with the blood pressure and pulse monitored once in the first hour of the postpartum. The trigger criteria for treatment include clinical judgment of the blood loss of more than 500 ml or the blood loss of more than 300 ml plus one abnormal observation. Any amount of the bleeding after childbirth which causes cardiovascular compromise or deterioration of the vital signs should be considered PPH. Primary PPH is defined as the blood loss of more than 500 ml within 24 hours after the birth. Secondary PPH is more than 500 ml blood loss after 24 hours of the birth of the baby. Minor PPH is the one in which the blood loss is between 500 to 1000 ml. Moderate PPH, blood loss 1000 ml to 2000 ml. Severe PPH 2000 ml or more. Estimates of the blood loss are notoriously low, often half the actual blood loss. Blood can be mixed with amniotic fluid and urine. The importance of a given volume of the blood loss varies with a woman's hemoglobin level before she gives birth. A woman with normal hemoglobin level will tolerate blood loss that would be fatal for an anemic woman. Anemic women collapse and die from hypotension, therefore avoid hypotension with early insertion of 14 gauge or 16 gauge IV cannulae and fluid or blood replacement. Bleeding can occur at a slower rate over several hours. The condition might not be recognized until the woman is suddenly in shock. Risk assessment in antenatal period doesn't effectively predict which woman will have PPH. Even healthy, non-anemic women can have catastrophic blood loss. Triggers for initiating treatment is blood loss of 500 ml or earlier at 300 ml plus one abnormal observation. We cannot predict who will experience PPH on the basis of the risk factors alone. Risk factors include over-distended uterus, prolonged labor, antepartum hemorrhage, severe preeclampsia or eclampsia, prolonged intrauterine death, cesarean section, previous cesarean section, and anemia. The possible causes of PPH include uterine atony, retained placenta or fragment, tears of the uterus, cervix, vagina, perineum, coagulation defect, inversion of the uterus, infection. For PPH prevention, antenatal care should include minimum 8 contact visits. Prevention, early detection, and treatment of iron deficiency, anemia, and thalassemia. For active management of third stage of the labor, we use uterotonic for the prevention of the PPH during the third stage of the labor. Oxytocin 10 international unit IV or IM is preferred uterotonic. The second line is ergometrine or methyl ergometrine 200 microgram IM or IV, but hypertensive disorders should be excluded prior to its use. We can use misoprostol 400 to 600 microgram orally. Carbetocin 100 microgram IM or IV is recommended for the prevention of PPH. The combinations of ergometrine plus oxytocin or misoprostol plus oxytocin may be more effective uterotonic drug strategies for prevention of PPH of more than 500 ml compared with the current standard oxytocin. The administration of the misoprostol 400 to 600 microgram orally by community health workers and lay health workers is recommended for the prevention of PPH. In setting where skilled birth attendants are unavailable, the control cord traction is not recommended. Sustained uterine massage is not recommended as an intervention to prevent PPH in the women who have received prophylactic oxytocin. Postpartum perabdominal uterine tone or contraction assessment for early detection of the uterine atony is recommended for all women. Oxytocin IV or IM and control cord traction is recommended method for the removal of placenta for the prevention of PPH in vaginal and cesarean delivery. Postpartum monitoring is recommended to ensure early identification and intervention in case of complications. The recommended checks include airway and breathing, circulation, vaginal bleeding, uterine tone, consciousness or conversion, abdominal pain, and temperature. The recommended timings is every 15 minutes from 0 to 1 hours after delivery, every hour from 1 to 4 hours after delivery, every 4 hours from 4 to 24 hours after delivery. Conduct more thorough assessment at 1 hour and discharge. For postpartum care, women should be monitored closely every 15 minutes during the first hours after delivery. Check vaginal bleeding, accurate blood loss measurement, uterine tone, pulse, and blood pressure. This picture shows the cumulative blood loss of 350 ml. Now, visual estimation of the blood loss is very important. What are the different methods of the blood loss assessment, which is usually underestimated issue? So first of all, we can measure the blood loss with under the buttocks drapes. Secondly, by visual assessment, which we will discuss, and by weighing the swabs or pads. 1 gram is equal to 1 ml. So from this picture, we can do the visual estimation of the blood loss. We can see that the soiled sanitary towel equals to 30 ml, soaked sanitary towel 100 ml, small soaked swab of 10 into 10 centimeters 60 ml, incontinence pad 250 ml, large soaked swab 45 into 45 centimeter 350 ml, 100 centimeter diameter floor spill 1500 ml, PPH on the bed only 1 liter, PPH spillage on the floor 2 liter, and full kidney dish 500 ml. Responding to emergency promptly and effectively requires that members of the clinical team know their roles and how the team should function. Organize an obstetric rapid response team in every duty shift. The ability of facility to deal with emergencies should be assessed and reinforced by the frequent practice or simulation emergency drills. When managing an emergency, introduce yourself. Ask the woman her name. If she is unconscious, ask for the woman's name from her companion. Encourage the companion to stay with the woman. Explain all the procedure. Ensure and respect woman's privacy during examination and discussion. Do not leave the woman unattended. Ensure emergency transport facility. PPH treatment should start with bundle approach. Use an under the buttocks plastic drape for accurate measurement of the blood loss with early detection of PPH. The first action is call for help and start uterine massage. Now for PPH prevention, there should be antenatal care, proper treatment of anemia especially, and active management of the third stage of the labor. In case of PPH, do early detection of the PPH to trigger treatment. Start treatment when the blood loss is of 500 ml or earlier at 300 ml plus any abnormal sign, and go for the first bundle then, which include uterine massage, IV fluid, ringer lactate or normal saline, establish the cause, give more oxytocin and tranexamic acid. The supportive measures include treatment of the cause, catheterize the bladder, and empty the uterus. The secondary bundle include bimanual compression, aortic compression, uterine balloon tamponade, non-pneumatic anti-shock garments, and the supportive measurements include blood transfusion, surgery, and referral. The type of the surgeries include uterine artery embolization, B-Lynch, ligation of the uterine and ovarian arteries, or hysterectomy in the end. This guideline emphasizes on PPH management flow charts using prevention, active management of the third stage of the labor, early detection, and the bundle approach. IV oxytocin alone is the recommended first line of the uterotonic drug for the treatment of PPH. If oxytocin is unavailable or if the bleeding doesn't respond to oxytocin, go for oxytocin argometrine fixed dose, but avoid in case of the cardiac and hypertensive patients. And another choice is the prostaglandin E1 sublingual misoprostol 800 microgram. There is no evidence about the safety and efficacy of additional 800 microgram dose of misoprostol treatment for the PPH to women who have already received 600 microgram of prophylactic misoprostol orally. IV isotonic crystalloids are recommended in preference to the use of colloids for the initial IV resuscitation of the woman with a PPH. Early use of IV tranexamic acid as soon as PPH is diagnosed but within 3 hours of the birth, in addition to the standard care of clinically diagnosed PPH, include 1 gram 100 mg per ml tranexamic acid slow IV at 1 ml per minute over 10 minutes. The second dose of 1 gram IV if bleeding continues after 30 minutes or if bleeding restarts within 24 hours of completing the first dose. Intramuscular tranexamic acid inhibit fibrinolysis within 10 minutes and may be suitable alternative to IV tranexamic acid when the birth attendant is not skilled to give the IV medication. So the initial management when a woman presents with a PPH include stay calm, choose one person in charge, shout for the help, assess airway, breathing and circulation, and early detection of the shock. If shock is suspected, immediately begin the treatment. Position the woman lying down on her left side with her feet elevated. Talk to the woman and stay calm. Perform rapid evaluation. IV cannula and needles are used 14 gauge or 16 gauge. Get blood samples, infuse IV fluid, take appropriate history and do relevant examination. Stabilize the patient, catheterize, and do appropriate documentation. We should know about the basic principles when providing the respectful care, and that include, where feasible, ensure that the woman has a companion of her choice with her. Provide information to the woman, but provide information to the family if a woman is unconscious. Take an informed consent as well where possible. Avoid using dextran because it can be harmful in large doses. Ringer lactate or Hartmann's are preferred initial IV fluid for resuscitation. If a peripheral vein cannot be cannulated, perform venous cut down. Now for infection prevention and control, consider every person as potentially infectious. Hand washing is the most practical procedure for preventing cross-contamination. Wear gloves before touching anything wet. Use barriers if splashes and spills of any body fluids are anticipated. Use safe work practice such as not recapping or bending needles, proper instrument processing, and proper disposal of the medical waste. About medication used in PPH, it's written that all of the drugs are available in the Pakistan except the carbetocin and carboprost. Argometrine is registered but not available at present, and be conscious about it, especially in hypertensive patients and in cardiac patients as well. So the first action is uterine massage, maintain IV line with the normal saline or ringer lactate, and give medications. Let us talk about the uterotonic drugs from this guideline. Oxytocin is given in the dose of 10 unit IV, 20 unit in 1000 ml normal saline at fastest flow possible. The continuing dose is IV 20 international unit in 1000 ml at 40 drops per minute. The maximum dose, about it's written that not more than 3 liters of IV fluid containing oxytocin should be given. Precaution and contraindication is that do not give IV bolus. Argometrine dose is IM or IV slowly 0.2 milligram. Repeat 0.2 milligram after 15 minutes if required. 5 doses, total 1 milligram. And be conscious in case of the high BP, preeclampsia, heart disease, and retained placenta. The dose of carbetocin is 100 microgram IM or IV over 1 minute. Maximum dose is 140 microgram, and it is contraindicated in case of the asthma and cardiac diseases. Carboprost dose is 0.25 milligram IM every 15 to 90 minutes. 8 doses maximum can be used as intramyometrial. The maximum dose is 2 mg and contraindicated in asthma and heart diseases. Misoprostol or prostaglandin E1 dose is sublingual 800 microgram and you can repeat 200 to 800 microgram. Maximum dose 1600 microgram. Prostaglandin F2 alpha IM 0.25 milligram and 0.25 milligram every 15 minutes can be given. Total 8 doses 2 milligram and it is contraindicated in case of the asthma. Tranexamic acid 1 gram IV slow over 10 minutes. Repeat after 30 minutes if bleeding continues, and the maximum dose is that not more than 10 milligram per kg body weight 3 to 4 times daily is given. What are the conscious points or in which condition it is contraindicated? No benefit after 3 hours. It means that it may harm when there is, especially when there is history of coagulopathy, IV clotting or convulsions. Now, clinical use of the blood products and replacement fluid is also discussed in this guideline. The appropriate use of the blood product is defined as the transfusion of the safe blood products to treat a condition leading to significant morbidity and mortality that cannot be prevented or managed effectively by other means. Conditions that might require the blood transfusion include postpartum hemorrhage leading to shock, loss of a large volume of the blood loss at operative birth, severe anemia, especially at the later pregnancy or if accompanied by by a cardiac failure. Prescribing the blood should be based on national guidelines on the clinical use of the blood, taking the woman's needs into account. Before prescribing the blood or blood products for a woman, keep in mind these things: expected improvement in the clinical condition, methods to minimize the blood loss to reduce the woman's need for the transfusion. Also think about the alternative treatments that could be given, including IV replacement fluid or oxygen before making the decision to transfuse. There should be specific clinical or laboratory indication for the transfusion. Also assess the risk of transmitting HIV, hepatitis, syphilis, or other infectious agents through the blood products that are available. Explain the benefit of the transfusion versus the risk of particular woman. Other treatment options, if the blood is not available in the time, should be considered. There is a need for the trained person to monitor the woman and immediately respond if a transfusion reaction occurs. We should do the monitoring of the woman who has been transfused. For each unit of the blood transfused, monitor the woman at the following stages: before starting the transfusion, at the onset of the transfusion, 15 minutes after starting the transfusion, and at least every hours during the transfusion. Now, intravenous replacement fluids are the first-line treatment for hypovolemia. Crystallites contain a similar concentration of the sodium as in the plasma that cannot enter the cell because the cell membrane is impermeable to sodium and pass from the vascular compartment to the extravascular space. There is very limited role for the colloids in resuscitation and they are more expensive than crystallite. It's very important to know that the colloid particles that are larger than crystallites raise the osmotic pressure. Colloids are usually given in volume equal to the blood volume lost. But there is no evidence that colloid solutions have advantage over the normal saline. Colloid solution may have an adverse effect on the survival. Human plasma should not be used as a replacement fluid. Plain water should never be infused intravenously. The maintenance fluids are crystallite solutions such as dextrose or dextrose in the normal saline, used to replace the normal physiological loss through the skin, lungs, feces, and the urine. If it is anticipated that women will receive IV fluids for 48 hours or more, infuse a balanced electrolyte solution, that is potassium chloride, 1 gram in 1 liter IV fluids with dextrose. Prophylactic antibiotics should be given because performing certain obstetric procedures such as cesarean birth, manual removal of the placenta increase the woman's risk of infectious morbidity. Where possible, give prophylactic intravenous antibiotic 15 to 60 minutes before the start of the procedure. 1 dose of prophylactic antibiotic, that is co-amoxicillin 1.2 gram or amoxicillin 500 milligram plus metronidazole 500 milligram IV or cefuroxime 750 milligram IV or cephradine 500 milligram IV is sufficient and is no less effective than 3 doses or 24 hours of antibiotic. If procedure lasts longer than 6 hours or blood loss is 1500 mL or more, give a second dose of prophylactic antibiotics. So giving antibiotic is very important because obstetric procedures for which prophylactic antibiotic is recommended for the woman include different conditions like placement of uterine balloon tamponade, cesarean section, third and fourth degree perineal tear repair, and the manual removal of the placenta, etc. It's very important to be aware of the symptoms and sign of the shock, which include the raised pulse, low BP, pallor, sweating, rapid breathing, anxiousness, or scanty urinary output of less than 30 mL per hour. So this chart shows how to do early recognition of the shock, which means reduced tissue perfusion in PPH, and the changes in the vital signs appear late when the blood loss is more than 1000 mL. Shock index is the ratio of the heart rate to systolic blood pressure. In standard obstetric, it is 0.7 to 0.9. In non-pregnant, it is 0.5 to 0.7. And more than 0.9 in case of the hemodynamic instability. More than 1 when the blood transfusion increased risk is there. Rule of 30 is also very important to know, which means loss of 30% of the blood volume, which means 70 mL per kg of the adult and 100 mL per kg of the pregnant woman. In rule of the 30, there is 30% fall in hematocrit, 30% fall in hemoglobin, 30 millimeter of mercury fall in systolic blood pressure, 30 beats per minute rise in the pulse. The specific management include IV fluids, venipuncture or a collection of the blood for the estimation of the hemoglobin, and the clotting tests. Continue to monitor vital signs every 15 minutes, catheterize the bladder and monitor the fluid input and output record. Give oxygen at 6 to 8 liter per minute by mask or nasal cannula. If available, apply non-pneumatic anti-shock garment as temporizing measure until the appropriate care is available, and or uterine balloon tamponade. Regarding the blood transfusion, it's written in the guideline that major obstetric hemorrhage protocol must include provision of the emergency blood with immediate issue of the group O negative and K negative unit with a switch to group specific blood as soon as possible. Assess the blood clotting status using bedside clotting test if coagulopathy is suspected. Now keep emergency treatment pack boxes ready in emergency trolley or cupboard. Emergency pack for PPH contain IV fluid, 2 liter normal saline or ringer lactate, IV cannula 14 gauge or 16 gauge, blood giving set, IV giving set, specimen tubes for the group and cross match, Foley's catheters, sterile gloves, uterine balloon tamponade, the different types of the drugs, oxytocin, ergometrine, misoprostol, and tranexamic acid. The emergency procedures include bimanual uterine compression or external aortic compression for the treatment of PPH due to uterine atony after vaginal birth is recommended as temporizing measure until appropriate care is available. If women do not respond to uterotonic or if the uterotonics are unavailable, the use of uterine balloon tamponade is recommended as an effective non-surgical technique. It's very important to learn the assembling of the uterine balloon tamponade. For that, wear sterile gloves to assemble on sterile tray and use the sheets and paper. And you can find the whole procedure of uterine balloon tamponade if you write on Obs and Gynae balloon tamponade procedure. Here, the placement of uterine balloon tamponade is shown. Fill the condom with 300 to 500 mL of the normal saline until the inflated balloons become visible in the cervical canal and the bleeding stops. Once the bleeding stops, close the wall of the IV giving set so no more fluid enters the condom. So once the bleeding stops, the woman is ready for careful observation or transfer to referral facility. So appropriate monitoring of the woman is extremely important. Now for uterine balloon tamponade removal, it's very important to know that the timing of its removal should be decided by senior clinician once the woman is stabilized. Now warnings about uterine balloon tamponade should be known. And it's very important to avoid the excessive force when inserting the balloon into the uterus and use 500 mL maximum inflation of the condom balloon. Now this picture from the guideline shows the technique of uterine balloon tamponade insertion, which include the preparation of the kit, first of all, the insertion technique, the inflation, and in the end, the deflation as well. The non-pneumatic anti-shock garment is an effective non-surgical device that should be in every health facility. The surgical techniques include B-Lynch, bilateral uterine and ovarian artery ligation, but before that, simplified brace suture should be used. Now, this table shows the transfusion products, components, dosage, and their desired effects. PPH bundle approach include good quality leadership, data monitoring and quality improvement, respectful maternity care, facility readiness, network integration, PPH emergency response, teamwork, and communication. So thank you so much. That was all about PPH guideline 2023 Pakistan. Subscribe on Obs and Gynae. Allah Hafiz.